Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. We have here a patient who travelled all the way from Canada to be treated by myself, and they attended the clinic today alongside their daughter. They had booked the appointment about a couple of months in advance, so they were planning their trip, and they arrived yesterday really late at night, I think at 11 p.m. In London, and they caught a train and they saw myself today at lunchtime, and tomorrow I think they're leaving the UK, and whilst they've travelled all the way to Europe, they're going to spend a few days in France. I think they've got some family there before heading back to Canada. So just to give you a backstory, this patient has been suffering from bilateral blocked ears, and in particular this their right ear, which has become a bit painful, as I said, for the last 5 years. And they visited their GP, they visited quite a few audiologists, and also they've been seen by a couple of ENT specialists, and they found it really difficult to remove this from, in particular, the right ear. And patient's been using drops, and the last time I think they had it attempted to remove was about a month ago, or probably a bit longer than that, was prior to booking their appointment, so probably a couple of months ago, and they just weren't able to remove it. And I knew it wasn't going to be straightforward, because if you've got several specialists, including ENT, who've tried to remove this, it's not going to be straightforward. But the complexity comes from several things, several factors. The midsection of the patient's ear canal is extremely, extremely narrow, and you won't see at the moment, and I'm kind of oblivious to it as well, although I had a slight inclination when I lifted the wax up. But as we go through the middle narrow section, the ear canal widens, it protrudes open, but their inferior recess is quite prominent. So the inferior recess is almost like a well, a pothole, a trench if you like, a basin at the floor of the ear canal adjacent to the eardrum. And this wax is lodged inside there, the tail end of it, which you can't see at the moment. And this wax, despite using the drops, it's really hard and stone-like. And it was a lot of pressure. The patient's travelled all the way from Canada to be treated by myself, and at this stage I was thinking, oh God, I hope I can do this. It's very seldom that I can't remove wax on the day. I think it's probably 1 or 2 a year that I have to get back on a second visit, and they're really, really extreme cases. And I think one I had to refer onwards because they needed a general anaesthetic to have a foreign object removed. So I've used the forceps. I brought this wax forwards, but it's just lodged here at the moment, and their daughter is really interested, because when I'm performing the procedure, you can see it in the room. You can just look over my shoulder and see it for yourself. So put a bit of oil, and they have got a few hairs here in the cartilaginous portion, which is somewhat smearing the lens a bit because they get oily. Now I'm using here a cawthorn, a variation of a cawthorn hook. Now I'm developing my own range of instruments, and one of these is going to be an ear pick, and that would have been just perfect for this procedure because it's long, narrow, and I would have been able to get right behind this where an ear hook or any other instruments wouldn't. So I'm really excited to launch that. I just wish I had it ready for this patient. So the cawthorn hook variation, should I say, it's just manipulate the wax, and I think I've lifted it out of the inferior recess. I'm just going back in because I did chisel it into little pieces, and you can just see how narrow this ear canal is. And the patient advised that when they saw the various specialists in Canada, and they actually, the daughter's a big fan of watches all the videos, and she sent the videos to her mum to take with her and show them the technique that I use with an endoscope. And they advised that they don't have this technology yet available in Canada. And we have trained a couple of people in Canada, but I'm just waiting for the launch of the wax scope before I really push technology and the instrumentation that I've developed around the world. So hopefully in the next year or two you'll be seeing a lot more specialists around the world using. I think with the endoscope, what I'm using here, it's just a bit more difficult because you do require a lot of training. So maybe we can find some really good trainers in the US and Canada or Australia, New Zealand, South Africa, all these countries where we've had so much interest. The wax scope is a device that you can probably, specialists can use if they're already performing microsuction with loupes or microscope, and they're comfortable using a specular, so it's less training involved. So I managed to remove that, and The patient was over the moon. Now, they have got a bit of eustachian tube dysfunction. The eardrum sucked in. I confirmed that with a pressure test called tympanometry. They do report blocked right nasal passage. In fact, both they had bilateral eustachian tube dysfunction. It would have been able to diagnose that once we've removed the wax. The handle of malleus, the hammer bone, is slightly inflamed because the wax was lodged up against that. I'm just going to mop up a bit around the edge for the patient. There was a bit of clarinetting with the skin, so when you suction dead skin, it does violently flap, and that flapping can limit a very loud, high-frequency squeal, which is really noisy, not only for the patient, for myself. So we have to be careful. A few flakes here and there just left. It's not worth potentially risking a temporary threshold shift caused by the noise over removing a bit of skin. Now, this patient, I have advised them I recommended some nasal decongestion spray, the Otavent nasal balloon, because they came all the way from Canada. I gave one of them today to the patient for them to use on the house, and I've advised the patient that they are very likely going to get a build-up again because of the ear anatomy. This dead skin that starts the migration off the eardrum. It's just going to get trapped in this midsection. So recommending the use of some softening drops on a regular basis, some olive oil medical grade spray, which is slightly acidic, so it mimics the acidity of the ear. Our ears secrete oils as well anyway, so you're going to get less potential reaction with olive oil medical grade spray compared to sodium bicarbonate or hydrogen peroxide drops, which are alkaline and water based, so two of the things that I don't particularly like in the ear. So yeah, the patient was overjoyed. They were really relieved. They got a bit, I wouldn't say tearful, but they were a bit emotional. Daughter was also quite emotional because I think it was a lot of pressure on the daughter. The daughters recommended the patient attend. So if they came all this way and I wasn't able to help, it would have all been the daughter's fault. And I airdropped the video to them so they can watch, and I know they're going to watch on YouTube as well. So they're very grateful. But yeah, it was at one stage I thought, oh, am I going to be able to do this? But I managed, and in good time as well. Now, similar problem with the left side. In fact, the left side initially probably a bit more problematic, and I can see why if you're not using an endoscope, this can be tricky, because with a speculum, most speculum only widen and dilate the cartilaginous portion, the outer third. The inner 2/3 of the ear canal is made of a bone, so you can put a speculum down in there, but it's not going to expand the bone, so it's not going to stretch that portion of the ear. So it'll just give you access, a speculum, to the outer third, the cartilaginous portion. So, but this wax is lodged in the medial section of the ear canal, next to the eardrum, so the bony section, and also the ear canal narrowing is, I would say, just where the cartilage meets the bone. So just more than a third of the way in. So the speculum will stretch that. It won't stretch the entire widening. So an endoscope for me is so good for these really tight procedures. When we first introduced endoscopic earwax removal in the UK, we had a lot of raised eyebrows. A lot of the status quo weren't happy, and tried to, without even knowing how to use an endoscope, give some falsehoods about it. And we had to, there was a kind of a guidelines, UK guidelines written, where they were being almost very negative of endoscopic, and we had to intervene, and that soon got stopped in its tracks, and it had to be rewritten, and we had an apology given to us, because, for example, they said we couldn't perform, it's not possible to perform endoscopic earwax removal in a narrow ear. Well, here we are. And whereas the traditional speculum method failed in the past with this. So this is where an endoscope, for me, comes in its own elements. If you've got the right skill level and experience and training, it's in the most tightest spaces. And there is a technique. So even if you've got an endoscope, you need to know which order to go in the instruments, how to stretch the ear canal, what distance, how far ahead the endoscope, or how far behind the endoscope is from the instrument. So there's a lot more to it, but yeah, so I would definitely, even with a microscope which I've got and with a wax scope, I'm always going to use an endoscope for procedures like this. Again, I've used that Cawthorne hook to really good effect. Now, because there's a gap, an opening there, it was effective, but what I've developed with the ear pick is going to be very, very good, even if there's minimal space against the side of the ear canal walls. So this eardrum, it said it's intact, slightly inflamed inferiorly, but they've got eustachian tube dysfunction here. So the eustachian tube is a narrow tube that connects the middle ear to the cavity behind the eardrum to the back of the nose, and it has two functions. It's the pressure equalizing tube in the ear. We want the air pressure behind the eardrum to be equal to the air pressure in the atmosphere. That's when your eardrum's most compliant. So the eustachian tube, it's normally shut in the normal resting conditions, but involuntarily, when we swallow, yawn or chew, the muscles contract where it connects to the back of the nose. It opens the eustachian tube temporarily, and the air pressure can equalize itself. And it's a drain pipe, so any fluid accumulation, because the skin that lines the middle ear is made of mucosa skin, which is secretory. Any fluid buildup can drain out of that. But if that eustachian tube gets blocked at the back of the nose, in this patient's case, they have got nasal congestion, they're already taking nasal sprays. The eardrum, there's no air behind the eardrum. It creates a vacuum effect. Your eardrum gets sucked in. It's like you're on a plane. So I'm just going to have another look. Otherwise, everything's fine. You can just see how narrow that ear is. You've got the two boulders here. They were rock solid, and you can see how dark they were. So I hope you enjoyed that video, guys. And to the patients who travel from Canada, thank you. I'm glad we managed to remove it. And have a safe journey back. Take care. Bye.